Good morning, everyone. We are down to our final 2 weeks of this Cardio-ECHO series, Your Patient with Diabetes at Risk for Heart Disease, a series of case discussions. And I'll go ahead and just pass it off to Dr. Rao so we can go ahead and get started.
Thanks to everyone for joining us again for our second last week in this series. I'm going to be leading the didactic presentation and one of the cases this morning. The slides for the didactic presentation, I want to give credit where credit's due to Dr. Trygve Dolber, who is a psychiatrist who is very interested in the intersection of metabolic disease and mental health, and actually refers patients to our Fit or Me obesity program here at University Hospitals. So Trygve was not able to be here today. So what I did was extract some of his key slides and key points, which I think are outstanding. I will also offer some of my own perspectives on these issues from a different ECHO series. So with that introduction, next slide, Rick, please. So these are our disclosure statements. I have nothing to disclose, and I don't think Sherry and I have anything to disclose as far as the cases go. Another reminder to use patient-centered language. I've noticed a significant improvement as we've gone through just this series in terms of how often people say people with obesity or people with diabetes, as opposed to some of the older terms. And some of these other recommended terms are also being adopted at a high rate. Next slide. So let's talk about mental illness and cardiovascular health. You know, it's interesting that I remember a physician a long time ago when I was practicing in Northern Ontario would care for a lot of patients who had schizophrenia in his primary care practice. They had a psychiatrist. And I said, well, why do you care for them? He goes, well, I feel for them because nobody else wants them in their waiting room. Other patients feel uncomfortable. They can be disruptive, etc. And it's got me thinking about how much mental illness must impact your medical care if people don't feel comfortable with you in a typical outpatient environment, where there are obviously certain expectations about behavior, that it could be a serious problem, and that the medical conditions these folks have, unfortunately, would deteriorate rapidly. Next slide. So the objectives are to describe the epidemiology and outcomes of diabetes among patients with chronic mental illness, the impacts of treatments for chronic mental illness, including atypical antipsychotic medications on weight and overall cardiovascular health, and 3 strategies to improve cardiovascular health, which I think is the most important point that Dr. Dolber has in his slide set. Next slide. So chronic mental illness is very common. So most of the mental illnesses we see in primary care are chronic. So they wax and wane, whether it's generalized anxiety disorder, bipolar disease, anything of this sort. And chronic mental illness is often interchangeably used with severe mental illness. These are conditions which severely debilitate physical functioning and are characterized by severe psychiatric symptoms. Of course, the best known is schizophrenia, but others are common as well. Next slide. So I think there's 2 points that come from this slide. First of all, that chronic mental illness complicates general health outcomes significantly. You think about in the obesity treatment world or patients with metabolic disease, Jim and I do see patients with chronic mental illness, and it does present a significant challenge if they don't have the organizational skill or the support, or sometimes the chronic mental illness is such a huge priority in relation to the other medical problems. We just want them to be able to function. So getting to a healthy weight, getting your diabetes under control is a rare is very difficult for some of these people. So chronic mental illness, as you can imagine, also reduces life expectancy, increases costs as well, and increases mortality. Next slide. The burden, I think, was quite striking from this slide. So that if you have a chronic mental illness, you have twice the risk of schizophrenia, twice the risk of bipolar disease. And as you can see, the risks for other cardiovascular illnesses is also elevated significantly. So we're talking about people who start with one of these mental illnesses. What's their likelihood of developing developing a cardiovascular risk. Smoking is extremely common among schizophrenic patients in particular. Next slide. So the risk of diabetes is much higher if you have depression, and the age is generally earlier. Why is a really important question, and I don't think it's easy to answer, which is what the point that Dr. Dolber is making. So first of all, these folks are likely to have well-established risk factors for diabetes, such as obesity. They may not be able to function in a toxic food environment as well as other people. And of course, there's treatment-related risks and disease-specific risks, which we'll talk about in a moment. Next slide. So why do patients with schizophrenia, why do they have an increased risk of diabetes? They may have a higher genetic susceptibility. So there is clustering, of course, of metabolic disease and mental illness. And this is something I think that is very, very poorly understood. Most people respond by saying, oh, there's a gut-brain axis, so it must have something to do with it. But we don't really understand it very well. But there's no question that people with mental illness have abnormal glucose metabolism, are more insulin resistant at a younger age, even if they don't have diabetes yet. And I think that's what he's trying to say. Now, the most common phenomenon I've encountered is, of course, the consequence of treatment with antipsychotic medications, which we'll talk about in a moment as well. The environmental factors are extremely critical. Generally speaking, people with chronic mental illness have lower financial means. They have a poor diet quality. They don't make great food choices. Part of it is the burden imposed by the mental illness, but part of it is simply that that's the priority, and those are the circumstances that they live in. That in order to function day to day, it's important to have their mental health symptoms under better control. And diabetes, hypertension, heart disease, or even quitting smoking becomes less important to them. So how do you minimize metabolic liability? So I can share my experience. Essentially, I think whoever prescribes medications for those for mental health conditions should at least start with a certain consciousness about the metabolic liability, as Dr. Dolber puts it. This is a phenomenon that is extremely intractable. At one point in this country, there were 3 million children and adolescents on atypical antipsychotic medications. And some of you may have heard of the famous New England Journal paper by Dr. Biederman, who said that childhood bipolar disease is extremely common. And prescriptions went through the roof. And everybody was happy for a while, right? The kid is calm, the teachers are happy, the parents are happy. The psychiatrist treating the child is getting a good result, but the consequences of that were severe metabolic disturbances, huge amounts of weight gain. At least being conscious of that is an important first step. So use medications with lower metabolic liability and limit off-label use. And if they are experiencing significant weight gain, they should be switched to other medications. Now, the metformin is a controversial area. Dr. Dolber has experience with this from the adult standpoint. The problem is so severe that at the University of Pittsburgh, we trained psychiatrists, child and adolescent psychiatrists, in weight management and to prescribe metformin at the time of prescription of an atypical antipsychotic drug. If they've been on it for a while, the metformin doesn't seem to have much effect. And of course, this applies for adults as well. If someone is considering prescribing an atypical antipsychotic drug, such as aripiprazole, Risperdal, et cetera, you would, first of all, advise the patient that weight gain is almost inevitable, that it can be minimized by following some basic habits, and of course, by prescribing metformin and titrating it up to a dose of 2,000 milligrams per day. And even then, there is a significant amount of weight gain with these medications. Next slide. So antidepressant drugs are associated with new onset of diabetes mellitus, unfortunately. Dr. Dolber has tricyclic antidepressants here, which I think in relatively high doses will cause substantial weight gain. And some SSRIs, such as sertraline and paroxetine, for example, are both associated with weight gain, though much less than with tricyclic antidepressants. Again, awareness is really important. Bupropion, which we use for weight loss, can cause a modest weight loss in combination with lifestyle changes. Most are weight neutral, but the diabetes risk is significant and is probably mediated mostly by increase in body weight. Next slide. So how do we deal with this issue? So the classic case is someone who has a severe mental illness, who is not functioning at a high level and is debilitated by this. And you are charged with dealing with their medical comorbidities. And that's typically where we are, because these folks really do need specialized psychiatric care for the most part. And there are far more of them than we know of in primary care because they don't come in very often. But when we do see them, we do need to take advantage of what goes on. So first of all, the standard diabetes education can be effective, but has to be altered because a lot of these folks do have some cognitive deficits, and their mood state influences how much knowledge they can accumulate. That's one problem. So it's just the diabetes education itself. So Karen Bailey, I think, who's on the call, would have her task cut out for her. But then after they leave diabetes education, they've got to implement what they've learned. And that's a really, really difficult thing for these folks. So reinforcement is important, keeping things as simple as possible. Of course, the most effective thing is making sure there's a caregiver there or a family member who can help out with the situation. I was supervising residents just yesterday. We had a situation just like this with an adult with a chronic mental illness who without his family members could not manage his metabolic condition. So you prescribe psychotropic drugs that minimize metabolic weight gain propensity. There used to be a big chart about the atypical antipsychotics ranked from lowest weight gain to highest weight gain, and I relied on it for many, many years. Aripiprazole was marketed as weight neutral initially when it came out. That had never been my experience. They're all associated with significant weight gain. There are lawsuits from patients who are stating that these medications gave them diabetes or gave them heart disease. That's how substantial it is. I've seen adolescents gain 100 pounds in the course of a year after being placed on these medications. So most atypical antipsychotics will cause significant weight gain. The key really is to use lower doses, to prescribe metformin, to make sure parents and family members and others are cognizant of this phenomenon, and the patient as well, which seems to have a significant effect. Optimize outcomes of psychiatric comorbidity. This is really important. So what I think Dr. Dolber is referring to is it is reasonable to say, gosh, I know you smoke. I know you're at high risk for heart disease. I know you have obesity, and I know you have diabetes, and none of those are really under tremendous control right now. But let's see if we can optimize your depression or substance use disorder to the best of our ability, and then we'll deal with these things. I think the rationale here is if you do not do that, you have no hope of normalizing some of these medical conditions. It's the same sort of thing. This is overwhelming for them, and it's very, very difficult to get a handle on it. Self-management support is important. This, I think, is the most important point on all of his slides, is that we cannot do this ourselves. So in weight management or in diabetes management, there has to be collaboration among professionals involved in the care of the patient. So critical to that is not just the physician or the specialist physician, but the diabetes educator and the mental health provider as well. Sometimes, just having a quick 3 or 4-way phone call to say, gosh, I tried to explain to this patient how she should take her insulin, but I don't think she understood. I did the best I could. And having that conversation with the mental health provider and say, I know that the symptoms are responsive to this medication, but is it possible to taper it down a little bit because it seems to be causing a significant metabolic disturbance? That seems to be the only approach that in the long term would have a significant benefit for these people. Next slide. Okay, thank you very much. I'm happy to answer any questions. with the caveat that I am not a mental health provider myself, but I did take a very close look at Dr. Dolber's slides and some of the studies that he had presented. So any questions before we move on? Perhaps Karen, can you give us some of your experience with these populations and what that's been like for you?
Sure. I'm thinking of two patients that stand out over the years to me that both had schizophrenia. And what I did with them is, and I mean, you can do one-on-one diabetes self-management training for medical reasons, for, different reasons. So if you have to bill and you can't do group, a person with schizophrenia, you could definitely do one-on-one and justify that. Just because of psychiatric illness and cognitive ability, and they just need a little more attention. And with both of them, I did one-on-one diabetes education, and then I also connected them with a community health worker. One of them had a community health worker that had diabetes, and he was another fella. This guy was a fella, and it was another fella, and they would meet at a McDonald's because they live far from each other, but they would meet at a local McDonald's. And the community health worker had goals that that we were working on, basically just getting this guy to have some regular meals. And so he really connected with the community health worker and improved, and his A1C improved. I mean, this is a guy that was just eating enormous amounts of chocolate at nighttime and wasn't eating meals. The challenge was that he stopped going and meeting with the community health worker, when he would have a psychiatric, crisis or whatever. And so it's really hard to keep them connected, with a community health worker. And then also, I think it's a little overwhelming for a community health worker that doesn't know much about mental illness. So it is a challenge. It's a challenge all the way around. He still comes to his doctor's appointments, but then he got angry at the doctor, and I think now he has another doctor. The other patient I'm thinking of, she went through diabetes self-management education one-on-one, and then she also went to a community program that I did for 6 sessions. So she got diabetes education twice, and benefited from it. And she was doing well with her lifestyle behaviors. But again, when a mental health crisis occurred, that's where it all falls apart. So I'm telling you, it is very challenging. I wish I could give an answer and a fix. Maybe somebody else can, but it's a kind of one of those things. It's a roller coaster ride up and down, and you have to keep engaging them and hoping that they come back.
Thank you, Karen. I think it's one of the core principles in a lot of echo cases is look for some small victories. The patient who comes back, who at least is taking one of their medications or has made a small lifestyle change. But I appreciate the difficulty. One thing I have seen done is group visits where people with mental illness and diabetes or obesity did not work, didn't go well at all, because mental illness is so varied, and they don't necessarily want to be in a group with others, with that sort of condition. There's a great deal of stigma attached to it. And one patient who may be disruptive or threatening to others can destroy the group. So that doesn't seem to be an approach. So I'm glad that you have some experience with the one-on-one part. Okay, thank you, Karen. And I think we can move on to our case studies.
Great, thank you, everybody. Just a couple of reminders. You'll have your usual post-clinic survey in your inbox, and then there'll be an additional survey. I think it's just a couple of open-ended questions for you all to submit either topics or questions for our wrap-up session next week. So it'll be our final week, and we're happy to address any gaps or elaborate on anything we've covered thus far. So just to let you know, you'll have 2 emails from me, and feel free to submit any topics of interest. And I think we're almost at 9 o'clock, so we'll adjourn for today, and we'll see you for our final week next week.
Thanks, everyone. Have a good day.
Thank
Bye-bye.
you.